Good morning. The prevalence of obesity has increased markedly in children over the last 20 years. As a consequence, we are now seeing complications of obesity such as type 2 diabetes that were only recently seen in adults. The treatment of childhood obesity is quite difficult and is very unsuccessful. Therefore, health professionals are looking into prevention measures, interventions that would lead to a decrease in the development of childhood obesity. I'm going to report on Healthy Bodies, which is a successful student-led elementary school program for the prevention of obesity and eating disorder, and it was developed at British Columbia's Children's Hospital in Vancouver. We're going to review what is Healthy Bodies. We're going to look at the program outcomes, not only for the pilot study that was performed in BC, but also for the implementation study that was performed in British Columbia in a much larger number of children. We are going to hear about the Manitoba experience by Dr. John McGavock, and we are going to see the status of the development of the First Nation and Inuit versions. Healthy Body empowers elementary school children to live healthier lives by providing them with knowledge about, as well as encouraging positive attitudes toward physical activity, healthy eating, and feeling good about yourself. It has several original and novel aspects. First, the most important in my mind is the body teaching or peer-led teaching aspect. In other words, older students, here called intermediate students, from grade 4 to grade 7, receive healthy living lessons and then deliver that lesson to their paired younger buddies from kindergarten to grade 3. It was quite encouraging to see how these pairs of children were bonding throughout the whole school year, with the younger children looking very, very respectfully towards the older children. The school comprehensiveness is another aspect of the program. The entire school is divided into buddy pairs, and the lessons are delivered weekly throughout the whole school year. Additional aspects are the comprehensive content of the program. It targets attitudes and behaviors about body image, nutrition, and physical activity. In addition, it is consistent with the British Columbia school curriculum, making it quite easy to implement. And finally, it is a ready-to-use kit. Therefore, no additional preparation work by teachers is needed, and no additional staff is required. We first performed a pilot study in British Columbia. It was funded with a grant from the Sick Kids Foundation. In contrast to the other studies that I'm going to describe later, this first study had an additional study teacher that was present for the implementation over the school year. It involved one intervention school compared with one control school, and the total number of children was 360, including all children from kindergarten to grade 7. The study was performed on the Sunshine Coast, which is about 40 minutes from Vancouver and can be accessed only by ferry. Healthy Bodies program included 21 weekly paired lessons for both older, intermediate, and younger primary students, 2 30-minute fitness loop sessions per week for the body pairs, and Go Live activity. The lessons were delivered using a variety of techniques, including presentations, card games, art activity, and so on. Here is an example of what the children are drawing. Watch less, do more. There was a progression in the lessons. The initial lessons were that body pairs had. While during these lessons they learned how to be positive buddies and learned the 3 components of a healthy life: go move, go fuel, and go feel good. In the subsequent lessons, buddy pairs learned the challenges of living a healthy life and how to overcome these challenges. For example, how to deal with advertising in the media. Here is another drawing. Let's go move. The fitness loops were as follows. Each body class participates in 2 structured aerobic physical fitness sessions per week. Again, that was the younger and the older buddies were really very close together and performing the activities together. There were different fitness loop teams every week, and these activities included relaxation and stretching at the end of the session. Here is what Emily tells us. I like to lay in the grass in the summer. It is very peaceful. Here are the results in the older students from grade 4 to grade 7. What you see in pink is the changes from baseline in knowledge, behavior and attitude assessed through a series of validated questionnaires. There is a modest and non-significant change from baseline. In contrast, in light blue are the changes that are observed in the intervention school. And as you can tell, not only is the change from baseline quite significant for both knowledge, behavior and attitude, but also there is a significant difference between the control and the intervention school. More interesting, these changes are also observed in the younger children from kindergarten to grade 3. Remember, these are the students who did not get the information from their teacher. They got the information directly from their older buddies. And you can tell in light blue, in the intervention school, again, the knowledge, the behavior and the attitude were significantly higher than in the control school. What about physical measures? We also measured weight, height and BMI. In the younger kids, kindergarten to grade 3, we observed a greater height gain and a slower increase in systolic blood pressure. You have to know that the blood pressure physiologically increases with age in children. In older children from grade 4 to 7, we observed a slower weight and BMI gain and a slower increase also in systolic blood pressure. What about the implementation? Following this first pilot phase, we then implemented the study in 46 elementary schools across BC. That involves more than 10,000 school children, and the outcomes were measured in 1,280 of these children. It was funded by the Provincial Health Service Authority and by the Child and Family Research Institute. There was one big difference in this implementation study and the pilot study, is that in this implementation study, the program was implemented by the existing staff, so there was no additional school teacher, and this was in order to demonstrate sustainability of the program. The results show an absolute improvement in knowledge, behavior and habits, and we studied also the perception of the program by the staff and the students, and the program was very well received. An important limitation is that there was no funding for a formal control group from this agency. And I believe this is a very important point that I want to make, is that any program, and there are so many of these, that is developed in schools should be evaluated in order to determine whether this program is worthwhile to perform or not. I'm going to talk about the Manitoba experience. Dr. John McGavock in Winnipeg was interested in using our program to implement it in several settings in Manitoba. A total of 647 school children were involved, and there were 10 schools for the intervention and 9 schools for the control. The schools were also in rural and urban areas. This slide showed the participating schools in Manitoba. On the right, you will see 11 urban schools close to Winnipeg, including 3 First Nation schools. On the left, 8 rural schools spread out in Manitoba, including also 3 First Nation schools. The results of this program are quite interesting. We see here the changes in waist circumference. In the left, you will see the changes in the primary or younger school children. On the right, the older school children or intermediate school children. In the darker blue, you see that the control school show an increase in waist circumference throughout the school year, and this contrasts with a decrease in waist circumference in the intervention schools in lighter blue. The changes and the differences in the primary students is about 1 centimeter, and the intermediate student is about 2.5 centimeter between the intervention and the control schools. More interesting, when you look at the differences between the First Nation children and the non-First Nation children, you see that the results are even more impressive for the First Nation children, where you can have up to a change of plus 1.5 centimeter in the control school, but minus 1.5 centimeter change in the intervention school. Knowing the major risk of First Nation population for obesity and its complications, this is quite interesting that this program may be specifically interesting for First Nation students. The difference in the results between the First Nation and the non-First Nation Chinoans was just borderline significance with a p-value of 0.06. What were the positive aspects of the program? And I'm going to quote a few people in Manitoba here. Students' relationships. The younger students developed a great relationship with older students in the school. Having students teach students is a great way for learning. The older students were so encouraging. Organized, thorough, and logical. 100% of the teachers who responded to the survey indicated that they would use this program or part of this program again. It is addressing a major issue in school. The program did a wonderful job of bringing out excitement in students about being healthy. What about the First Nations and Inuit versions? Well, we performed the cultural adaptations of our original program in collaboration with the community stakeholders. In particular, in the Inuit populations, there was a specific request that all the figures were be entirely redrawn by an Inuit artist. The program in Nunavut is presently being implemented. In the First Nation, there was an implementation and an outcome analysis which is ongoing, and this was performed in the Hartley Bay area in northern British Columbia. Here are a few examples of the changes of the First Nations and the Inuit card, for example, for the food choices compared to the original program. In this First Nation card, you can see that we mentioned shellfish, hogfish, moose venison, and this is reflecting more typically the foodstuff that's available for these populations. This slide is an Inuit card, and you can see that we also include caribou meat, peas, baked char, dried fish, cloudberries that again are not present in the original version but reflect more typically what is available in Nunavut. This card shows the games that are more specific of Inuit population, such as cutting wood, mushing, ice hockey or floor hockey, snowshoeing, string games, and you will also note the figures themselves that have been redrawn by an Inuit artist who did actually a marvelous job. This card is in the First Nation version, and you can see that it emphasizes different type of games or outdoor activities such as hunting and power walk. So in conclusion, peer teaching can be an effective tool to increase health knowledge, behavior and attitudes in both primary and intermediate elementary school children. We have seen from the pilot study and from the Manitoba experience that this can translate into physical changes such as a slower weight or BMI gain or a decrease in the waist circumference. Again, I want to emphasize that peer teaching reflects the fact that the older children are directly teaching the younger children, and that we also found a marvelous bond forming between these older and younger bodies. Here is the team, the original team with Dr. Sue Stock, who did come up with the concept of this program. Valerie Ryden and David Barnum, who are the two teachers who contributed to the development and the implementation of the program. Stacey Evans, who was our research manager, and myself. More information can be found on our website, www.healthybodies.ca, and you will find also a link if you had any questions regarding this program, and this program can be ordered from our website also. Thank you very much for your attention.